All right, the next presentation is going to be Michael.
If someone want this video, I can share with you. No problem.
Next presentation on the sites and symptoms of vestibular migraine. Michael.
Thank you, John, and so nice to see all of you here, and always wonderful to be back here at the Teresa. I'm going to speed through a topic that I think that is really important to all of us, because vestibular migraine is a big problem in our clinics. It's a high percentage of our patients, of which we've become more and more aware of in the last 20 years. It has started to eclipse what we thought were the most common vestibular disorders. We have a few goals here. We're going to quickly review a pathophysiologic model of migraine, and then we're going to take a look carefully at how migraine mechanisms could create vestibular symptoms in three major areas: in the supratentorial, infratentorial areas of the central nervous system, and then from the labyrinth itself. And I think this is a useful way to think about this going forward, because we have to start parsing out these patients into treatment groups who are separate from one another. Migraine itself is really common, about 11% worldwide prevalence, and of course the big story since medical school has always been the blood vessels which are throbbing and hurting, and we've all learned that, but we never learned very much about what might be going on in the cortex, and certainly and even less about what could be going on in brainstem centers in migraine episodes. Vascular changes do indeed occur, but they may actually be incidental, because headache starts hours before vasodilation becomes maximal. It's not the vasodilation that makes a migraine episode, not even the pain of it, and we're just concerned with the dizziness, and the pain resolves even during vasodilation, hours before vasodilation ends. So there's something else going on, and that seems to be related to trigeminal outflow. All of the blood vessels in the intracranial space are innervated by unmyelinated C fiber branches from the trigeminal nerve. These are loaded with inflammatory peptides. This kind of a venom is secreted around the vessels and sensitizes them to pulsation, whether they are vasoconstricted or vasodilated. These, if you want to know what meningitis feels like, ask a friend who has migraine headache. They have chemical meningitis. Of course, these get secreted in the sinus and nasal mucosa, causing symptoms that mimic allergy, mimic rhinosinusitis, and are likely even secreted around the blood vessels in the inner ear. Now, visual auras, which are classically associated with migraine attacks, result from electrical disturbances in the cortex. Carl Lashley, a physiatrist in Boston in the 40s, famously drew his visual scotoma as it expanded centrally and hypothesized that there must be a wave of spreading excitation followed by depression, moving about 4 to 6 millimeters per minute. A few years later, across town, Aristides Leao, working in the lab of Hollowell Davis, the godfather of auditory physiology, someone who Eric LePage knew directly. We're honored to have you, Eric, to hand down that legacy of experience. Well, he was working. Aristides was working on a seizure model, showed this to his mentor, was told to forget about it because it was an artifact. He published it anyway, and later on it was discovered really to be the phenomena that spreads across the cortex electrically and accounts for a great variety of aura symptomatology. Now, another feature of chronic migraine, which is very important, even episodic migraine, is that there's a rather consistent increase in activity in the superior salivatory nucleus. This means that there's increased parasympathetic outflow in migraine attacks. These are very important for otolaryngologists because of the lacrimation, rhinorrhea, nasal congestion. But as vestibular scientists and clinicians, we should be aware of the orthostasis and the motion intolerance that can occur, motion sickness that can occur with upregulation of the autonomic system in migraine. And the fact that, then this is just to show how system-wide in effect this actually is. So let's consider vestibular symptoms in migraine, looking at supratentorial and infratentorial, and then inner ear possibilities separately. So obviously we know that balance is an integration of inputs from proprioceptive from the inner ear, and each inner ear is 5 vestibular organs. Some are rotational and other are linear accelerometers and visual motion. But it's really what we're concerned with today is the central integration of inputs that allow us to stay oriented in space, static, and in movement. And when we look at how complex the vestibular system is because of this integration of all of these systems, we can just imagine, it's almost unimaginable, there are an enormous number of possibilities for dysfunction and even types of dysfunction in the system. So in general, vestibular migraine patients have more dizziness than migraine patients alone, and vestibular migraine patients are more motion sensitive than migraine patients, all of whom can remember being sick in the backseat of the car as children. So these vestibular migraine patients very often report an unusual array of vestibular symptoms if you only will listen and be the first one to acknowledge the strange stories that they have to tell us. This is an example of spreading depression in the visual cortex in a migraineur who has exercise-induced migraine. He got off the basketball court and into the functional scanner. This is the most common site of spreading depression, but in the vestibular system, unlike other sensory systems, does not have a discrete cortical area of expression with any hierarchy. Because of its interactions with the somatosensory system and the visual system, it has a very diffuse projection to the cortex. And so, but although recently the right hemispheric parietal opercular area, OP2, has been identified as an area that seems to almost always light up with vestibular stimulation. On the right, you see a panel. This is just saccadic eye movement. So you can imagine that if cortical spreading depression is happening in some other area of the cortex, it could cause hemiplegia, it could cause migrating numbness, it could cause a very unusual, strange sensations where patients don't have the capacity to describe their experience. They just don't feel right during these transient episodes. The thalamus is probably the greatest area of convergence of inputs in the entire central nervous system. And we know that this is where awareness of motion between the thalamus and the cortex occurs. And converging projections are unique. Converging projections are subject to a phenomena called convergence amplification. So we know that there is a convergence of dura-sensitive neurons and of vestibular projections in the thalamus, and if they converge and amplify one another, this could explain why there is sensitivity to head motion for some vestibular migraine patients, even when they're not having a migraine pain episode. This may be similar to the photophobia mechanism described by Remy Bernstein, who demonstrated increased firing of dura-sensitive neurons with light, with convergence with retinal afferents. Dizziness from the thalamus is capable, dysfunction in the thalamus is capable of creating tremendous distortions in our spatial awareness, Alice in Wonderland syndrome, feeling that you're not really talking from the place in the room where you are sitting. When patients tell us they're walking on foam and they have a proprioceptive distortion, or they're in a bouncy house. Some of these symptoms may be so strange and very difficult for a clinician to deal with that it's easier to give the patient a diagnosis of PPPD rather than take on the possibility of trials of medication for migraine. And I fear that a lot of patients are mislabeled. Only a only about 6 weeks ago, I saw a 78-year-old gentleman with essential tremor that was so severe that he could not feed himself. He had a focused radiation treatment to the thalamus, in the ventral intermediate nucleus of the thalamus, not shown here because it's medial to the ventral posterior lateral nucleus and the ventral lateral nucleus, which received the greatest number of vestibular projections. So they cured his left hand, but they missed on the right side. And he now has a proprioceptive distortion on the right side where he feels his right leg is not long enough to reach the floor, as if the floor will tilt it away from him. There's no change in the subjective visual vertical, and we can only hope that this recovers. We've all maybe heard somebody say that, there was this period, I experienced this very scary period for about 20 minutes where I was out and I had really no way to find my way home. Well, these are experiments done in laboratory animals all the time about route finding, and all of this, this kind of spatial awareness and route finding comes from activity in the hippocampus. There are many different cell types which encode our place, and you can have errors in visual pathfinding as well. You may have a functioning vestibular system, but because you can't create a visual path, you may unfortunately bump your frozen shoulder into the door jamb far more often than is necessary. Patients tell us about these things. We have the otolith pathways are much more complex than the central pathways of the semicircular canals, because they, in order to accommodate translational VOR, they have to adapt for the direction of gaze and a distance to the target, and so they can result in, and any distortions in the central pathways can cause tilting effects that may be transient and or a sensation of constant falling. Rocking sensations and imbalance. If you have a chronic imbalance because you're veering, well, there is a tendency to try to compensate with your vestibular vestibular spinal reflexes to tilt back in the other direction, which is not really necessary because you're not really tilting, and then that results in a kind of unsteadiness that is difficult to recognize and treat. And of course, Ashley mentioned the cognitive implications and the special power that the otolith dysfunction has on our cognitive function. The most extreme sorts of tilt illusions have to do with room inversions rather than just tilts, and this often is related to abnormalities in the insula. Infratentorial dizziness is a little bit more straightforward, or at least we think we understand some of the mechanisms here. We can always pick out the side of a migraine episode because of the increased metabolic activity in the dorsolateral pons, the site of the trigeminal nucleus in a migraineur. But that is not the only site that lights up, and every migraineur has its own pattern of increased metabolic activity. Superior salivatory nucleus is one that I mentioned that's rather consistent. But if the vestibular nuclei are activated because they receive stimulatory activity from the trigeminal nuclei, which may be activated, the locus ceruleus, and dorsal raphe. The locus ceruleus is a general alerting system which spreads to the entire neocortex. Then you can have distortion of vestibular information leading to disequilibrium, head motion intolerance, visual motion intolerance, like OKN disturbance, frank vertigo, and these patients will tell you by the time they get to see you that they've taken typical anticholinergic vestibular suppressants which work on the semicircular canals pretty effectively, and there was no change in their symptoms. Now, we know that there is an otolith problem where you need the semicircular canals, otherwise the otolith system cannot tell the difference between translation and tilting, so that the information from the canals and the otolith organs are sent to the cerebellum, where they are integrated. And the nodulus and uvula in the base of the cerebellar vermis project inhibitory connections that are GABAergic to the vestibular nuclei. This is a basic vestibular physiology. And we know that electrical stimulation of the nodulus and uvula will actually shorten the VOR time constant, and that which is related directly to velocity storage. Velocity storage is something that, we think, resides in the intercommissural fibers of between the two vestibular nuclei. And it's quite possible that in migraine there is some sensitization of the nodulus and uvula that is inhibiting vestibular function, that decreases velocity storage and decreases the VOR time constant. And we find this in patients with vestibular migraine. Now, Richard Lewis and his group has demonstrated that there is an error in a change in the convergence of otolith and semicircular canal fibers in these patients with vestibular migraine. And this is distinct from normal controls in patients with migraine. They're unusually sensitive. And especially at mid and low frequencies, and they included patients who had migraine but no vertigo, and episodic vertigo but no migraine. When they looked carefully at the intensity of symptoms, when the tilt thresholds were really, really low, the symptoms could be severe or mild. And there were another grouping of patients who seemed to correlate quite tightly with the symptoms and the tilt thresholds. So in vestibular migraine, they're even related to the VOR. So does this suggest, this was interesting because it suggested that maybe there are two phenotypes in vestibular migraine, but there's actually a little bit a better explanation, and that is that this is a continuum of states that occurs in an individual who has primary activation probably of the vestibular nuclei, because in migraine attacks it's getting stimulatory activity from the trigeminal nuclei, the dorsal-raphe, the locus ceruleus, and it becomes so activated that it has to be restrained. So an adaptive response is an alternative hypothesis. It's not that the nodulus and uvula become sensitized, that it becomes hyperactive in order to control the hyperactivity in the vestibular nuclei, and that there's some oscillation. So when we treat these patients, we want to treat them and control migraine to decrease this central brainstem activation. But we also want to enhance the work of the nodulus and uvula by giving GABAergic medications. And we find patients who are really resistant to this. It may be that their GABAergic inhibition of this system is saturated. And we have to be patient, try different agents, and combine both treatments together. A lot of these patients have extreme optokinetic sensitivity. If you have optokinetic stripes on your phone and you hold it up to them, they immediately recoil. And this is because of this dysfunction in the interactions between the vestibular nuclei and the nodulus and uvula. There may be problems with velocity storage that prevent this otherwise helpful reflex from being tolerable. And so they have difficulty in life, not in supermarkets, driving over bridges, driving in traffic. It's very disabling for them. They also, every migraineur is motion sick, but vestibular migraine patients are extraordinarily motion sick. And we don't really understand very much about motion sickness. It only exists since we developed ways to move artificially in boats and in cars and trains. So there's conflict between two streams of information here, but also there's a conflict with an expected state. And in vestibular migraine, because of these oscillations in time constant, VOR, which usually are somewhat labile, it may be very difficult for a patient to understand or predict accurately what should be happening with any head motion. So this expectation is a constant, factor that destabilizes their system. So all of these symptoms are autonomic, and as mentioned before, the autonomic outflow is already hyperactive in these patients. So is it central or is it peripheral? Well, that's the age-old question, and maybe it's both. We know we can create vestibular stimulation unilaterally by stimulating V1 electrically in migraine nerves, and we know that in the inner ear we can cause these C fibers to dump all of their contents by giving capsaicin, and that results in changes in blood flow, curiously, a threshold elevation of about 10 decibels across all frequencies that's reversible and is associated with a slight blunting of the tuning curve, suggesting some sort of outer hair cell effect, but no broadening of the tuning curve. Electrical stimulation of V1 was demonstrated by Zoltan Bass to cause manifest extravasation of protein, transmural extravasation in the cochlea, and compared to controls. But this was electrical stimulation. It's really profound stimulation, and this was only in the auditory system. But Carrie Balaban demonstrated a couple of years later that in intralabyrinthine superior and inferior nerve segments also showed this protein extravasation in response to serotonin stimulation. Because stimulating serotonin receptors, which we also know are in the inner ear. So could this whole cascade of events with extravasation of inflammatory peptides and vascular changes be going on in the ear? It's quite possible, and it may be that for some patients, some susceptible individuals, migraine could be a complication, or Meniere's disease could be a complication of migraine. Over time, there are fewer C fibers, impaired cochlear blood flow, and we have gone through all of the changes, all the similarities between migraine and Meniere's disease in many forums in the past. Even Prosper Meniere was pointing us in this direction in his initial publication. And we know that a lot of the patients we see don't fit neatly into one box or another. Only about 15% do, and the rest are in some place in this space in between, so demand both treatments. Now, the fact that some patients do have some labyrinthine weaknesses is testimony to the fact that injury can occur in the inner ear from migraine. And so it's maybe not so surprising that there is a strong association between migraine and BPPV, or the odds ratio, if you're about 7.5 times more likely to get BPPV if you have migraine than someone else. And you can see the female to male predominance, especially in menopausal years. And about 1/3 of migraine episodes occur during a migraine attack. So in summary, we know that there are supratentorial areas in migraine pathways, in our vestibular pathways, which are very complex, which can become distorted. The symptoms that occur in the supratentorial areas are a phantasmagoria of different sorts of distortions and illusions. In the brainstem nuclei and cerebellum, we have infratentorial symptoms that are more recognizable to us probably, but we also have to consider labyrinthine causes, and to try to treat anything that we can see so that we can prevent a reciprocating system of feedback, because vestibular symptoms have an unusual, because of their very wide projections, ability to stimulate and tip the central nervous system over into generalized migraine activity. So it's important that if peripheral disease is present, get rid of it. And if you have a patient with vestibular migraine and they also have concurrent BPPV, send them to physical therapy and get their otolith disease controlled, but you then have them back so you can save them from the trauma of unhelpful physical therapy visits, which last 40 minutes, even though the dose of therapy they can tolerate is about 6 minutes. We have to keep in mind that the current classification for vestibular migraine is really strict. It's for, and most of our patients won't feed it. They should not be used as exclusion criteria for treatment. They're for drug and epidemiologic studies. And of course, most all of these patients have chronic migraine. They're having symptoms over half the days of the month. They need migraine management. And if you feel like they do have these infratentorial picture, do consider going to GABAergic agents. Clonazepam is really helpful. It treats the coincident anxiety. Acetazolamide, propranolol is actually helps with GABA, and topiramate has some. Topiramate and other sodium channel blockers can prevent the sodium channel gated release of GABA in this reciprocating circuit between the nodulus and uvula and the vestibular nuclei. So, and if you see the inner ear and migraine, treat both. So, thank you very much.
Question for Michael. Paul?
Great talk, thank you very much. You have a great experience within this area. Could you elaborate a bit on CGRP, your stand on calcitonin gene-related peptide?
Well, I think it is, migraine and CGRP are,
Yes,
are two ways
migraine.
of saying the same thing. Does that molecule play a unique and decisive role? Perhaps not. We know that a lot of patients with vestibular migraine, their vestibular symptoms seem to be more durable than the headache symptoms, which are more amenable to treatment. They respond better to both the biologic and the smaller molecule CGRP receptor inhibitors. So there's something else happening than just the CGRP, but migraine is still there, and there are other agents which we haven't studied very well, other inflammatory mediators, and also serotonin clearly has a role to play. Some of these, and I should mention venlafaxine, which seems to be the serotonin drug of choice, actually is a GABAergic, your increased GABA activity, which is inhibitory with venlafaxine, which is the reason that it seems to work better than other SSRIs and some of the SNRIs.
What is your go-to regimen? You highly suspect vestibular migraines, they may be having Meniere symptoms. What's your go-to?
Yeah, my go-to is I start out, if they're older than 50, then I start with tricyclics, nortriptyline at low doses. And the reason that I do that is that if you cure the migraine, usually a migraine headache, then the vestibular symptoms often diminish simultaneously. Nortriptyline is unique. It does have SNR activity, but it's rather weak for headache control. What it is that most people aren't realizing is that it is a medium potency sodium channel blocker, a medium potency calcium channel blocker. It is anticholinergic, which offsets some of the increased parasympathetic outflow. It is all tricyclics are synthesized from antihistamines, and they retain some of their antihistamine effects, so you should have them stop them before caloric testing. And one other important feature is that they help people sleep better. And some of these patients just aren't sleeping. And often that is the kind of chronic fatigue event in life. They have to get up to urinate. They have a shoulder that wakes them up 9 times a night. They live with chronic fatigue, and they raise up over their migraine threshold, and their brain starts misbehaving. They're always wondering, why is this happening to me now? Why is it happening?
Do you start them at 10 milligrams?
10 milligrams up to 20, yeah. And then I consider 20 milligrams an index dose of nortriptyline. Almost everyone who's going to respond to it responds at least some at that dose. I don't waste that much time. When I see patients, I say, we're going to start you on this. In fact, we're going to find a medicine that works for you and that is tolerable. And if in 10 days you know that there's no way you can continue to take this because it's intolerable until your next visit, you call and say, I'm ready for plan B. If in 4 weeks at the full dose, you are not feeling better, we want you to call and say, no problem with the medicine, except I can't tell any difference. You call, you say, I'm ready for plan B. And when in that first visit, based on their other medications and medical conditions, we make a plan A, B, C, D, E, and then I execute the plan. And I can have nurse practitioners and other fellows execute that plan and without having my clinic clogged with patients who are coming back constantly. This is an effective way to deal with the increased visit load of treating chronic vestibular migraine. Yes?
Thanks for the great talk and the insight into the work. So how long do you give the drug a chance to work? 4 weeks, 8 weeks, 12 weeks?
4 weeks at the full dose.
Okay.
I'm not a believer that you need to wait 3 months.
Thank you.
Otherwise you spend a year or more, and most neurologic conditions have a tendency to chronification, and they can become more durable. So I think that I tell people in the next 4 to 5 months, we're going to find what works.
Okay, great, thanks.
We want to leave time for Ashley, but
Yeah, probably need to move on.